This next module will primarily cover different pain-related disorders, and this presentation in particular will cover arthritis. Again, with this presentation, we'll talk about the prevalence and risk factors, as well as symptoms and common treatment options for arthritis. Primarily in this presentation, we'll be talking about two kinds of arthritis, rheumatoid arthritis and osteoarthritis. We'll start with rheumatoid arthritis, which is an autoimmune disease, and it is more common than people may realize. Rheumatoid arthritis is the most common systemic inflammatory disease, and the impact of the disease is significant. For men who have RA, on average over their lifetime, they will earn about 50% less than men without RA, and for women that goes up even higher to about 75% less than what a woman without RA will make over their lifetime. Rheumatoid arthritis is a chronic, painful disease that can result in disability. Because rheumatoid arthritis is an inflammatory process, this creates an exaggerated risk for death from cardiovascular disease. Cardiovascular disease is the #1 reason why patients with RA die. Conversely, osteoarthritis is a disease of wear and tear of the joints. So osteoarthritis develops over a lifetime from using the joints, and primarily the weight-bearing joints are affected. OA is especially common in those over 65. For most people who live long enough, there's a high chance that they will develop OA. The joints just wear out over time. Osteoarthritis ranks second only to cardiovascular disease in causing severe chronic disability. Let's take a little pretest to get a sense of what you already may know about osteoarthritis and rheumatoid arthritis before we dive deeper into the presentation. Take a look at some of these questions and think about whether you think they are true or false. Even though osteoarthritis and rheumatoid arthritis are both diseases of the joints, they do have significant differences in the causes, symptoms, and presentation of the diseases. Rheumatoid arthritis is an autoimmune disease. The immune system is attacking the joints. This can lead to systemic symptoms of inflammation, including fatigue and weakness. The joint pain is usually symmetrical, and it usually presents with significant morning stiffness, and it typically affects more than 3 different joints. Commonly it's seen in the hands and wrists. Part of the diagnosis process includes radiographic erosion of the joints, called rheumatoid nodules, and positive rheumatoid factor identified in the blood. The age of onset for rheumatoid arthritis is 30 to 40 years old. On the other side, in the right-hand column, osteoarthritis is the destruction or loss of cartilage. It's a disease of wear and tear. And symptoms include pain, creaking, cracking sounds, and instability of weight-bearing joints. It often affects these weight-bearing joints like the knees, hips, and spine. You usually see it in older patients. However, you can see it in younger patients if there has been injury or surgery to a joint. It usually presents asymmetrically. This picture shows an example of some of the joint changes you can see in OA and RA. The normal picture on the left is for comparison. In the OA picture in the middle, you can see that there's no more space between the two joints. And people may call this, they may say things like, my knee is bone on bone, meaning that all the synovial fluid and cartilage is gone, so the patients are really having their bones rubbed together without cushion. This is very painful, and the joints aren't as structurally sound when this is happening. In the rheumatoid arthritis picture on the right, you can see there's significant swelling of the synovial membrane, and this swelling is typical in the inflammatory and immune response. Let's cover some definitions that we'll be using throughout this presentation. Inflammation is a local response to cellular injury. It is characterized by redness, warmth, swelling, and heat. Inflammation serves as a mechanism for initiation and elimination of the offending agents in damaged tissue. This inflammatory response is generally a good thing for your body, and your body reacts this way on purpose. However, the problem is that when the inflammation is chronic and it never shuts off, then this can really start to damage the body. Anti-inflammatory agents are agents that work to decrease the inflammatory response. Analgesics are used to block the sensation of pain, and antipyretics are agents that are used to reduce fever. It's important to know that a single agent may fit in all of these categories. An NSAID like ibuprofen, for example, can reduce inflammation, help limit the pain cessation, and also reduce fever. So an NSAID is an anti-inflammatory, an analgesic, and an antipyretic all at once. And finally, we'll talk about disease-modifying antirheumatic drugs, or DMARDs. These are used in rheumatoid arthritis to inhibit the progression of the disease, and these agents do interfere with the immune system of the body, trying to stop the damage going on with the joints. RA is an autoimmune disease, and family history does appear to be a risk factor, so if someone in your family has RA, you're at an increased risk of developing it yourself. RA is much more common in women, which is true for many of the autoimmune diseases. There also may be some environmental factors that put people at risk for RA. For OA, obesity is at the top of the list because the joints have to work harder and are under more stress if they are carrying around extra weight. Another risk factor is jobs that require repetitive movement of one area of the body are at a greater risk of wearing out the joint sooner. Sports and injuries are another classic way to accelerate the rate of OA. Also, family history does seem to play a role in osteoarthritis. The diagnosis of RA and OA are based primarily on symptoms and history. There's not a singular test or physical finding that confirms the diagnosis, although patients who have RA will have markers of inflammation and these rheumatoid factors. However, it's really a cluster of symptoms that are consistent that lead to the diagnosis. So for RA, that includes stiffness in the hands and the joints that are affected. You will see some joint changes. You may see some joint changes on X-ray. And for osteoarthritis, you'll see a patient who has asymmetrical symptoms, creaking and cracking. And for OA patients, you can also see bone on X-ray, which can help with diagnosis. The goals of therapy are similar for both types of arthritis. We want to relieve the pain that the patient is in and help prevent any further damage to the joints. We want the patient to maintain a normal quality of life to be able to do normal activities. If we don't treat or we undertreat the arthritis, both of these conditions can lead to significant disability. The first-line treatment for RA are the DMARDs. These work by inhibiting the immune system so that the immune system stops attacking the joint. You want to start a DMARD as soon as possible. The current thinking is that a patient will continue on a DMARD forever, and that's at least with our current knowledge. Classic agents include methotrexate, and we still use this pretty commonly, but also a newer and very common medication used is Humira. Both agents interfere with the body's immune system. This is why the side effects are generally related to immune suppression. There can be other symptoms related to cell damage that is caused by this immunosuppression. For osteoarthritis, the first-line treatment is high-dose acetaminophen. This works by inhibiting pain messages, and it also can reduce fevers. It works centrally in the brain to interfere with the pain messages. It doesn't really have true anti-inflammatory effects. The use of high-dose acetaminophen does come with some risks, including liver toxicity. You want to be careful that the patients are not going over the maximum daily dose, and this is especially true for patients who drink alcohol. You may want to avoid using Tylenol in someone who is abusing alcohol, as the risk of liver toxicity is greater. You want to make sure you're obtaining a good history for your patients and deciding if it's a good choice to use or not. Another important thing about using Tylenol for OA patients is that it often needs to be used in a more scheduled or regular manner for it to really be effective. If patients say that Tylenol was not effective for their OA pain, you first want to make sure that they were taking it scheduled and regularly and not just on an as-needed basis. NSAIDs can work for both RA and OA. They work well as a pain reliever and also work great for RA because NSAIDs have anti-inflammatory properties. These agents work by inhibiting the prostaglandin synthesis by inhibiting the enzyme known as cyclooxygenase. This enzyme is also very commonly referred to as the COX enzyme, and you may have heard it as the COX-1 or COX-2 enzymes. These enzymes are both important in the pain response. You may have heard about these enzymes in relationship to a controversial medication known as Vioxx, which was taken off the market quite a few years ago now at this point. This agent was selective in that it was a COX-2 selective inhibitor. The advantage of being selective for COX-2 is that there's less gastrointestinal adverse events. What we worry about first with the NSAIDs is GI toxicity. The COX-1 enzyme in particular is important in helping the lining of the stomach regenerate the mucosal barrier. So when the COX-1 enzyme is inhibited, the stomach can't do as good of a job as repairing this barrier. This puts the stomach and the GI system at risk of developing an ulcer, which can lead to bleeds and can be fatal. The COX-2 selective inhibitors reduce this risk, but the risk still exists even with the COX-2 selective inhibitors. We also worry about fluid retention, which can be significant and can lead to hypertension and strokes. There's also a risk for kidney injury or kidney failure. By inhibiting these enzymes in the kidneys, you can decrease the blood flow to the kidneys, which can lead to kidney damage. The NSAIDs also have platelet effects. With NSAIDs such as ibuprofen, these agents reversibly inhibit the platelets. This means that as soon as the drug has left the body, the platelets go back to normal and are able to act in the clotting function. There are also cardiovascular effects and risks. There is a risk of hypertension and hypertensive crisis, as well as stroke, related to the agents that interfere with the COX enzymes. This risk may be greater for the COX-2 selective agents. The only selective agent left on the market is Celebrex. But these cardiovascular effects are still a risk for the non-selective agents as well. So we want to be careful when using these products in patients with a documented cardiovascular risk. So as we mentioned, we would not want to use NSAIDs in someone with serious kidney dysfunction or active GI problems or cardiovascular disease, especially cardiovascular disease exacerbated by fluid retention, or anyone with active bleeding or bleeding disorders. We want to be very careful, and they may not be a good candidate for NSAID use. As I mentioned briefly, NSAIDs have had some controversy surrounding them, specifically with Vioxx, and even though it's happened over 10 years ago, you may still hear about it, and it also has impacted how we think about the treatment of these conditions and other conditions. Vioxx was withdrawn from the market voluntarily by the manufacturer, but there still were documented increase in heart attack and strokes associated with its use. And while this may occur with the non-selective NSAIDs, it does appear that the selective agents put people especially at risk. So again, we don't use these agents anymore in patients who have documented cardiovascular disease. We also worry about using these agents with aspirin together, and this is for a few reasons. First, there can be the increased GI toxicity when used together. Aspirin also inhibits COX-1, so the GI risk is exacerbated when the agents are used together. Also, aspirin is routinely used to prevent strokes because of its antiplatelet effect. So for aspirin, the antiplatelet effect is permanent and irreversible, so new platelets have to be made for normal clotting function to return. As we said before, other NSAIDs only reversibly inhibit COX, so the platelets can still have clotting function once the NSAID leaves the system. But with aspirin, the antiplatelet effects are irreversible for the life of that platelet. So if a patient does need to be on both aspirin and an NSAID, you would want to give the aspirin first, at least half an hour before, so that it can permanently inhibit the platelets before you give the NSAIDs. There are many things that patients can try and do to improve their outcomes that are non-pharmacologic in nature. First, weight loss is important for both types of arthritis. Patients with RA should rest, but not too much, and they should not be immobile. A moderate type of regular movement is best. You just don't want to overstress the joints. Rehabilitation and surgery may sometimes be options. Also, dietary supplements are another option. Folic acid, vitamin B6, B12, vitamin D, and magnesium have all been associated with positive symptom relief. So many of these supplements and vitamins play a role in inflammation and the inflammatory response, which may be why they are beneficial in RA. For osteoarthritis, the second choice is NSAIDs after the high-dose acetaminophen that we already talked about. Another option is glucosamine and chondroitin. Some patients see really good results, but it doesn't work for everyone. And there are also many different formulations, so it's important to understand what you're taking. For patients who may want to try glucosamine and chondroitin, it's important to let them know that it will take some time for them to see results, often a month or longer. We generally tell people to try glucosamine and chondroitin for a month or two, and if they still do not see results, they likely just do not respond to this agent, and it may not be beneficial for them to keep taking it. Another option is a topical agent called capsaicin. This is an irritant, and it takes a few days to work, but with constant exposure to the irritant, the nerve messages and pain messages eventually shut down. So basically, if you stimulate the nerves so much, they just shut down in response and stop sending the pain signals. So for it to be effective, it has to be used chronically, and it will take a few days to work. Another option is intra-articular joint injections, which can be done a few times a year, but these can get very expensive. Another non-drug therapies include exercise, weight loss, and physical therapy. Let's pause for a post-test self-assessment. Name 3 differences between OA and RA. What is the first-line treatment for RA? What is the first-line treatment for OA? List 3 potential adverse events associated with NSAID use. So take a second and pause the presentation and jot down some of your answers to these questions. If you cannot answer these questions, take some time now to review your notes. So in summary, RA and OA are common diseases that can lead to significant pain and suffering. RA is an immune condition associated with inflammation, and OA is from wear and tear of joints and overuse of joints.